So the topic is superficial femoral artery from basics to balloon and intervention perspective. I have nothing to disclose. So healthy feet beautify your personality. And hands are the symbols of unique craftsmanship of God. But if we neglect the care, it can become like this. So 2/3 of high-level imputation in those with peripheral arterial disease received low-intensity assessments. So they are not properly assessed in the OPD and then later on by diagnostic tools. So which result, if intervention is not done, we see 63% imputation in 1 year. And those whose angio is not done, or CTA or invasive, 92% are those who will end up in amputations. And remember, 46% of the patients have above knee amputations. So these are the risk factors already described by Dr. Masood's age more than 65. If age is between 50 and 65, then you need other risk factors for that. Age less than 50, mainly diabetes is responsible. Symptoms, mainly claudication. It can be critical limb ischemia, rest pain, and physical examination. You have abnormal pulses, bruit, non-healing ulcer, low extremity gangrene, etc. So peripheral arterial disease, it can be asymptomatic. It can lead to chronic symptoms that can lead to acute limb ischemia, or it can lead to asymptomatic patient can leads to critical limb ischemia, and then it become acute limb ischemia. So superficial femoral artery is unique. It is one of the biggest artery in human being. 50 years before, when the first intervention was performed by Charles, after that the intervention is mainly done percutaneously because it has low morbidity and mortality as compared to open surgical intervention. So while performing intervention on superficial femoral artery, we need these forces. We should remember these forces, that is extension or contraction, torsions, compressions, and flexions. Because if we put a stents, we have to be aware of these forces. It can lead to stent fractures. So how we do it, usually access, first you have to determine where is the lesion, contralateral, ipsilateral, left brachial artery, rarely use ipsilateral retrograde sheath. We have these guiding sheaths, ancel, Belkin, destination, etc. Guide wire, it can be cornice 0.014 or 0.18, which is really used in our institution, and 0.35. And support catheter, we can use ordinary diagnostic catheter, 4 or 5 French, MP, Rubicon, or Prograde microcatheters, or any cornice microcatheter. So I will be presenting 2-3 cases. This is a 66-year-old who had PCI, and he was diabetic, long-standing, presented with claudication, even sometimes the resting chest pain. Left femoral pulses was palpable while right was absent. ECG was showing normal sinus rhythm, and echo shows EFO 50%. This was his CTA. We can see the right SFA is occluded from the origin. So we started with fluoro-guided puncture, but unfortunately, we entered into the vein. So we tried to find the stumps. It was a stumpless CTO. Each time we want to wire the stump, it would slip into the profunda. Then we have some hope.
Very thin vessels. Lot of collaterals.
Tip injection confirmed that we were in true lumen. We balloon it multiple times, but there was rapid recoil and dissection, so we have to stent it.
How many stents?
This was the final angiogram.
How many stents?
Only one stent. These are long stents, so this is a self-expandable nitinol stent, flexible. This was another patient who was 70-year-old. She had presented with this ulcer. She was long-standing diabetic. Her coronary and peripheral angio was already done in other center, Ali Raza centers. Her ECG shows normal sinus rhythm. Echo shows preserved EF. So we can see MIC. So we can see we tried, sorry. Initially we tried with different cornice wire like a Hornet Pilot 200, but we could not enter into the true lumen. So we switched to 0.35 knuckle Chirumo.
What are the criteria?
So immediate after post wiring, we can see we have achieved flow distally. After prolonged ballooning, and at the ostium we needed a bigger balloon. So this was the final. This is another case. He's 75-year-old diabetic, was referred by endocrinology department with resting pain, and there was some ulcer as well. She was known chronic coronary disease patient as well, had PCI done 7 years back. ECG showed normal sinus rhythm, echo, preserved EF, RFTs were normal, CTA left SFA total occlusion.
So what was the diabetic control like, Jabbar?
It was not controlled because she was already admitted in, I don't remember exactly, in our endocrinology unit. So we advanced the NSAID sheets, telescoping were the right diagnostic catheters. We initially tried to do true intraluminal wiring, but we failed. We have to advance the diagnostic support catheters to have some support. Again, it failed. So we switched the procedures to 0.35 inch guide wire to have a knuckle. But we ended in this dissection, but the flow was there. We called our vascular surgeon. He said keep her for 48 hours. If there is no acute limb ischemia symptoms, we don't need to intervene for time being. We called the patient after 3 weeks. This was her angiogram. So this time our wire passed easily without any problem. After multiple inflation, balloon long inflation, we achieved this flow. So SFA and popliteal ideal, what should be the ideal strategy? More elaboration on balloon angioplasty with adequate size, at least 2 to 3 minutes, mostly finalized with DCB. But in Pakistan, it is hardly available and it's very expensive. If the lesion is calcified, hard SR lesion, plaque modification with debulking, scoring balloon, peripheral IVL or NC ballooning should be done. If the stent is CTO, then jet stream, NC or DCB, no stent zone, then we need DOT, heavily calcified in mid to distal SFA, we need self-expandable stents. Poor balloon response, primary DES. So how we do it in our setup, because we know we are resource limited. For short lesion, only PT and balloon angioplasty is enough. DCB leaving nothing behind. Every effort should be made to avoid stenting, because we usually these patients need future intervention to avoid the chance of stent fracture and ISR burden. With broad anatomical applicability, we should try to leave nothing behind. But DS, because leaving writing behind for poor response to plain balloon angioplasty. In these cases, we need drug-eluting stents or bare metal stents. So where there is a will, there is a way. Thank you very much.